Preparedness Seminar for December. As a reminder, Public Health Preparedness has a seminar on the first Wednesday of every month, except in January at 8 p.m. Eastern Time. So we're here together tonight. So the next one would be in February. We'll take January off since that's immediately after the new year. Before we do get started with tonight's seminar, I do want to remind folks that we do offer PHP 596. This is an individual studies course. A lot of students aren't really very familiar with it, but this is a course in which students design their own course around a topic or some sort of work or research that interests them. So we've had students in the past that have used it to study a specific topic, things like preparation for tsunamis in California, or loss of fever in Nigeria, or even the health of migrant children as they cross the southern border of the U.S. Some have used it to design intervention efforts too. So for instance, people have used it to develop a preparedness program for university students in, for example. Others have used it to organize and conduct and evaluate town halls on pandemic preparedness. So again, preparing a community for a potential pandemic. And then finally, some students have used it to do to arrange an actual internship then as well. So this is a good way, internships are a good way to get a foot in the door with a particular company or agency or governmental organization. Or if you're looking for a career change. So people have used it for that. It can be taken for between 1 and 9 credits, but it really is designed by the student. So if you have interest in that, please let me know. Oh, I didn't introduce myself. This is Gene Lengrich. I'm professor in public health sciences and director of the public health preparedness option here. So if you are interested in the 596, shoot me an email and be happy to talk to you about that and what that might look like. Most students that do take it later on in their curriculum when they've got a little bit of the required coursework under their belt and have an idea of what they really want to specialize in within the program. But that's enough about the program here. What I do want to do is introduce Charlotte Palmer-Roy. She is our speaker for tonight. We're really delighted to have her here on board to teach. She has a lot of qualifications, one of which I'm very proud of is that she's an alum of our program. She graduated with her master's in Homeland Security back in 2012 and has worked particularly with PHP 530 and will be continuing to do that in the springtime. So she brings a lot of training as well as real-world experience in preparation for emergency situations, particularly from the hospital or healthcare system. In addition to having her master's from Penn State, she also has a graduate certificate from our program as well. Another graduate certificate from Boston University. This one's in emergency management and organizational continuity. She is a graduate of Newton Wellesley Hospital School of Nuclear Medicine. She actually began her career in nuclear medicine and has worked her way up to the Director of Hospital Safety as well as the Emergency Management Coordinator then for Newton Wellesley Hospital. She also assists with Harvard School of Public Health in emergency planning and evaluation of programs as well. So with that, I'm going to pause and just in terms of procedures here, so let's all put our mics on mute except for Charlotte so that we don't give her any interference. And we will hold the questions till the end of the seminar, and then I'll facilitate those. If you don't have a microphone, you can go ahead and write your question in the chat box, and I'll ask Charlotte that for you then. Charlotte, you want to take it away?
I will. Thank you, Gene. I appreciate the opportunity to speak with all of you tonight. As Gene said, I'm a proud graduate of the Penn State program, and as we go through, I want to sort of highlight some of the topics that were helpful or have been helpful for me in many ways during my actual work at the hospital and in other venues. One thing that you will that's very important in terms of working in emergency management and working through a lot of the courses in the program is teamwork. And it was never so evident as it was during the Boston Marathon bombing events, as well as the preparedness for the marathon that we go through every year. I will be using the Boston Marathon as an example tonight of planning in response to large-scale events, but I'm not really going to be focusing on the event itself. I think many people are very familiar with that, but it's a good example of how the emergency management cycle is used and the importance of mass casualty planning in all arenas, not just in hospitals themselves. So we'll talk a little bit about mitigation, which is how can we best prepare for to keep something from happening, preparedness for events, response and recovery. So I talk about finding the balance in protective planning because following any event, whether it's a bombing at the Boston Marathon, something that we hear that's happening globally, we tend to be very reactive in Homeland Security. We're always reacting to the last event. But that's how we learn, and that's how we get better, and that's how we get stronger in how we plan and how we respond. So much has happened in the wake of the Boston Marathon bombings in terms of how we actually prepare for not only future marathons, but also for any type of large-scale event. It could be Democratic National Convention, it could be a marathon of any kind. So some of the things that we have done, and not just at our facility, but in our region, we've worked with behavioral awareness training. We're going to talk a little bit about that. Mass casualty considerations, agroterrorism. These are all things that you learn about during the course of the curriculum for the Homeland Security program. Campus protective measures, communication, sheltering in place, CBRN, long-term recovery, and finding the balance. Is this the new norm? So we're going to cover some of these topics as we go through here tonight. So just to talk a little bit about some of the planning that is done just on the facility level for us, we make sure that we have plans in place for any planned large-scale event. And it includes multiple departments within the hospital. It's not just emergency management, and it's not just the emergency department. This involves many departments, and every area actually has a checklist that we use as part of our planning. Some of the items that are on this checklist are worked on and planned for days or weeks ahead of the actual event itself. And some of what's on this checklist is used actually on the morning of the large-scale event. One of the important pieces, and this list has actually grown over the years, multi-agency planning for any large-scale event is huge. For the marathon, obviously, we're working with the Boston Athletic Association, local fire, police, EMS, public health, but we also work on the state and the federal level. ATF is involved, regional law enforcement, our state emergency operations center is open, as well as our state Department of Public Health Emergency Operations Center, Department of Homeland Security, FBI. Red Cross has been instrumental in working with our state public health on patient tracking methods in case there's a large-scale event. It's always a challenge for reunification of families if there's an event and people are separated. We have a tracking method that we use. So in any of the hospitals or any of the medical tents along the route, if someone comes in to be treated, their information is actually entered into a computer system that is accessible from all the hospitals, as well as the medical tent at the finish line and a patient or a family reunification tent at the end of the finish line, so that if family members are looking for anybody who may have stopped off in a medical tent or maybe in a hospital, we can quickly locate where that person is. All along the route, there are agents from FPI, ATF, National Guard, and State Police that all the way throughout the entire route. One thing that we have done in our region over the last couple of years is we developed these simulation tabletop boards, which we have found to be very, very helpful. This is just an example of a board of our particular decontamination area on the right-hand side, inside and outside of our emergency department. The green circle that you see on the left-hand side is just an example of a hot zone. We actually did a tabletop exercise prior to the marathon last year, and the actual scenario was a chemical explosion in one of the college chem labs down the street. So we have, you can see little ambulances and little pieces and parts, and everybody at the table. It's sort of like a Monopoly game, and you throw out a scenario and everybody has to move their staff around into different areas. And at the very end, if you can see in the center of that green area, we actually have, let's see, there's 6 contaminated firefighters. And the fire captain in the gray t-shirt is looking down at the group of contaminated firefighters with sort of a look of awe on his face. So things can move in directions that you don't always anticipate, but it's a great exercise. We do this for surge exercises. We've done it for a lot of different things. So these simulation boards have been used around our region, and actually there are different areas around the country that are using them as well. So one of the things when we look at planning that we have to look at year to year, whether it's a marathon or any event or any current threats that we might face, we need to identify what the threats are, and these change from year to year. So one year, if you look at the people that have a chain of people across the highway during the Ferguson protests, so we had to make sure that we were looking for people that may have these bright colored caps. That was what the Regional Intelligence Center was giving us information. You know, there's always the issue of potential of terrorism, whether it's homegrown or ISIS or any other type of a terrorist event. We look at target hardening for any of our critical infrastructures, one of which would be hospitals. We look at what might be soft points for demonstrators or high media points. When you look at an event such as a marathon, you have a lot of media at the beginning, you have a lot at the end, and in the case of the Boston Marathon, there's an area called Heartbreak Hill where there's always a lot of media. So you want to look at timing of media, you want to look at location of media. Those are areas that might be targets. And the photograph on the bottom right-hand side, this past year, there was concern of vehicle-borne incidents that might be moving into the crowds. So we actually had school buses and dump trucks along the route at cross streets that we might be able to throw out such an event. We also do some behavioral awareness training, and this is important for not just your fire police, your law enforcement, your ATF and FBI, but your frontline employees. So we've done some SAVE training, which is security awareness and vigilance for everyone. And we've done with our public safety officers, the Patriot training. Law enforcement has more extensive training, the BOSAR training and the AWR training. And these are nationally recognized programs that we have found to be very helpful in preparing our staff. We have quite a bit of campus security and facility access control during any large-scale event. We happen to be located, and I'll show you a map, but our facility happens to be located about halfway along the route for the marathon itself. So we have SWAT team members and K9 units present on our campus, not only to protect our critical infrastructure, the hospital, but also because we're a good location for them to stage in case anything happened along the route. They would be able to fan out in a timely fashion. We make sure that we have access control is restricted to patients, visitors, and staff. Any employees who are there have to have their IDs in order to enter the facility. We don't allow any deliveries or any construction on the day of any planned event. This year and the last couple of years, bags and people and vehicles were subject to search. We did have parking restrictions, and this directive came directly from the state and the federal level that we could have no parking within 60 feet of the route. We also moved our ambulance staging rather than right up against the building, which is the norm for our ambulance bay. So we have a separate staging area that's directly away from the building. So all unloading of patients takes place away from the building. So some of the spectator guidelines that came out of, I'm not quite sure whether this was a federal or whether this was a state poster that came out, but these were items that were restricted along the route, and anybody that had bags coming into the facility or along the route were subject to search. So a lot of campus protective measures that put in place. Our hospital is actually directly on the route. So we are pretty much an island on the day of the marathon. The marathon runs directly in front of our hospital. So the only access to our facility is through a dirt road in the back of our parking lot in the rear of the hospital. And it's only one-way traffic. So we have to basically triage the vehicles coming in and out so we can prioritize ambulances that need to come in, staff that need to come in. But it's a very small area, so we do have fire apparatus on campus that we pre-stage in the morning in case we actually had an event on our campus, because we could have a fire at the same time they're having marathon. We set up the mass decon unit, the tent you see down in the left-hand side. So that's something that could be used for decontamination if there were an event directly along the route. They actually do also set the center part of these up in a couple of areas along the route that they can use as misting tents. One thing that we always have to look at in terms of the marathon itself is what's the weather going to be, because depending on what the weather is depends on what our last minute preparedness efforts would be from a medical standpoint. If it's going to be extremely hot, we need to have ice immersion, tubs and ice and different supplies on hand for that. If it's very cold, we need to make sure that we have hot bouillon and drinks to warm the patients from the inside, bear huggers to warm them. So usually the marathon is always on a Monday, and usually on Friday we're making last minute adjustments to what we're going to need in terms of a medical response within the hospital itself. Top right hand side, you'll see we have the NEMLEC SWAT teams as well as the canines that are on campus. That actually picture, if you look in the background, that is the route directly in front of our facility. The SWAT team is standing in our driveway, and you can see the crowds that are running by directly across. And then there's our friendly Black Hawk helicopters that drive along the route. They're there on marathon day. They actually, for 2 or 3 days prior to the marathon, there are also helicopters that fly across that do baseline radiation testing all along the route to make sure that they have a baseline for anything in case there were an event. They would be able to have some comparison of radiation levels in the atmosphere. On our campus, we actually have, this is part of our decontamination emergency response team. It's a multidisciplinary team that works alongside of our emergency room staff as well as the fire department in the event that we have an event where we have to decontaminate multiple people. We have the yellow decontamination tent that can be set up by the fire department. But in the outside of our ambulance bay, we also have 4 outside showers, and then we have 3 inside fixed showers that we can use in the event that we have to decontaminate anyone. So one of the things that was new following the year of the actual bombing was a concern over the food supply. We have a tent where we have a barbecue, we have food, and we have about 2,000 between employees and the community. We serve about 2,000 people on that day. It's pretty well publicized. It's been done for years. And so there was a concern after the bombing that somebody might try to do something to taint the food supply that could easily sicken or do worse for a large number of people. Anyone along the route that has food that they're selling have to have licenses from the city. We're on private property, so we don't need to have a license, but we did want to make sure that we had some access control to the food that we were supplying. So instead of anybody being able to serve themselves, any food was behind the servers and they would serve everything forward. Everything that was in the tent was individually wrapped, such as brownies and chips. And so there, we tried to minimize or mitigate as best we could the potential for anybody able to slip anything unwanted into the food supply. So you can see the fence that was around there. We also did have some access control. We had bag checks, and we actually had a spot where people could leave their bags in a security area outside of the tent space. So route security was very high. The section in front of the hospital, there's probably about a 1 mile section from the highway up to, well, about a 2 mile section. There were about 150 first responders just in that route, some in uniform, some not in uniform. You can see that we have barriers out to the street itself so that they don't want anybody going out onto the route. And you can see the ATF agent on the right-hand side. The dogs they have dogs that actually sniff out the entire route from the beginning to the end in the morning prior to the actual starting of the race. So we also have, because we have so many spectators that come onto our campus, we actually have porta potties. We have probably 25 porta potties. We have been told that what we need to do now is they are delivered on Friday. They have to be locked until Monday morning when those poor dogs get to sniff the porta potties to make sure that there's no explosive devices within the porta potties. So every little detail makes a difference. So some of the issues about response for the marathon, but also for planned and unplanned events, it's important to have an emergency operations center that is a designated place that everybody knows where it is. Everybody's comfortable in how to use it. And it's a place that anybody within our facility knows where we are. If they have an issue, they need to come and see us. It's actually the upper left-hand picture. You can see that's actually just a regular conference room that has some cabinets. When you open up the cabinets, we have a pull-down desk, we have computers, we have radios, we have incident command information, we have maps, we have all kinds of information in there that we can manage through an event. We have a fairly low threshold for activating our command center, which makes it a lot more efficient when people do gather there, that they're comfortable in using the space. Communication is always the issue that comes up if you look at after actions from events going back hundreds of years. Whenever there's an event and you go through your after action, which is a very important part of having working towards improvement, multi-agency communication is huge. And many of the courses that you'll take during the course of the Homeland Security program are very much focused on teamwork. And if you're not comfortable working in a team in the course, it's going to be difficult for you to work in a team in real life. So it's something that hopefully we can help you build on during the course of the curriculum. So it was very confusing for me and for many people in the year after the marathon that there were certain agencies that we didn't normally communicate with in terms of command center to command center, and who we call for what type of information. So I actually had put this together of who to call, what I'm calling them for, and how I'm going to actually reach them. And I've taken the phone numbers out of here, but this actually has direct phone lines. So this is actually provided to all the different agencies in our region so they know how to reach us. That's the NWH, that's Newton Wellesley Hospital Emergency Operations Center where I am located, our emergency department. And then we have the city EOC, the Boston Athletic, the Wellesley has a huge medical tent, the Medical Intelligence Center in Boston, the State Emergency Operations Center in Framingham, and the Mass DPH Emergency Preparedness Bureau in Boston. So there are different agencies that are able to assist us for different issues during the course of the day. So talk just a little bit about the marathon and the route itself. If you look at the map on the left-hand side that shows you the 26.2 miles from Hopkinton into Boston, and the red cross there is where our hospital is located. We're at 16, mile 16. And the concern for many of us always has been, but more so now, is that there are no trauma hospitals between the start and the finish line. So Newton Wellesley is in the center. We are not a trauma hospital. However, if something goes boom, you are a trauma hospital. It doesn't matter whether you're a 20-bed hospital or whether you're a 400-bed hospital. So we're going to talk about that a little bit. So the day of the actual marathon event started out as a beautiful day. It's kind of a nightmare in Boston in terms of traffic congestion because it also coincides with the Red Sox home game. And if you look at the picture on the right-hand side, that's some of the runners coming down Route 16, just right outside of our hospital itself. You can see why you can't get there from here. We are at mile 16.5. We oftentimes have many runners and team members from our hospital that are running in the marathon itself. We also have many of our employees that work in the medical tents at the beginning and at the end of the tent. So at the beginning, there is one little tent which has a few of our staff from our rehab that can help with stretching and salt pills and whatnot, but there's really no medical assistance in that tent at all. The large tent at the end is where the majority of the medical support is located. So at 2:49, everything changed on that day when the 2 pressure cooker bombs were exploded. There was significant professional and medical response at the finish line. Fortunately or unfortunately, this happened right near a medical tent. There were 1,000 medical employees or medical volunteers who were there who were able to respond. Fire, police, and EMS were already staged there. Multiple ambulances were already staged there. So this really made a huge difference in the fact that they were able to get all of these patients out of the area and into hospitals. I think the majority of them were in hospitals within 18 minutes of the actual event. So just looking at some of the response that we had on the hospital level, and this was not just our hospital, but all of the hospitals, we use what's called WebEOC. It's a web-based emergency operations center. It's a virtual emergency operations center where hospitals, fire, police, EMS, they can all post significant incidents for all of us to watch what's going on out in the field. There were rumors of secondary devices along the route. The actual route was stopped. There was rumors of a threat to one of the Boston emergency departments, so it was temporarily evacuated. We had to institute increased surveillance within our facility, outside our facility, and obviously along the route. There was discussion there may be military-style duffel bags or an unattended backpack, similar to what they saw where the bombing itself took place. So the race was actually stopped. And where we're at the 16-mile mark, if you have somebody that's run 16 miles and all of a sudden they stop, people start to crash down pretty quickly. So we set up a respite area, but we staffed it with some medical people. Few people we did have to transport up to our emergency department as a result of stopping the race so quickly. We typically see on a normal or warm day, probably 70 runners in our emergency department in the course of 3 to 4 hours. So it is considered a mass casualty event for us, but we are trained and used to treating the types of medical emergencies that come with that type of a patient. And the patients are typically fairly young, fairly healthy, and they're able to turn around quite quickly and be discharged fairly quickly. And some of them go right back on the route and run. So one of the issues in the city of Boston was they had a lack of amputation kits. There were actually 16 victims or patients as a result of the bombings that lost their limbs either that day or within subsequent weeks. We had a lot of staff that were working at the hospital who were very concerned for their family members and their coworkers at the finish line, to the point that they could hardly concentrate on their jobs. So that made it very, very difficult to manage. We tried to set up places where staff and could try and reach out to family members. There was a lot of issues getting through with cell phones, not because they were shut off, as some people thought they were, but just because of the volume of calls that were going through the Boston area. What was probably a more significant challenge for us on the day of the bombing, because we were not in a location where we were receiving the trauma victims, but on the Friday following, we had a shelter-in-place order because the bombing suspect, one of the bombing suspects had been identified and had been killed, but his brother was still at large. He was believed to be on the run, possibly seeking medical care, and possibly wearing a suicide vest. He was subsequently captured 4 miles from our hospital. A shelter-in-place order was put in place for many of the communities surrounding Newton. The public transportation was closed down. We were not allowed to bring any additional staff in, or not able to bring additional staff in. We had staff that were at the facility. We couldn't mandate that they stay, but we recommended that, for their safety, that they stay. We were not able to get supplies, which is a challenge in hospitals where you're in a position where typically you have just-in-time deliveries every single day. We weren't able to get a lot of our patients discharged out. However, there were 2 hospitals that were on diversion, and all of their patients were coming to us. So we were pretty much busting out at the seam. We have a collaborative effort for our labor and delivery area with the Brigham and Women's Hospital in Boston, and many of these patients were not able to get actually into Boston to reach the Boston hospitals. So we actually had some of their patients that came to us were a little on the outskirts, so it was a little easier and safer for them to come to us. So this was the National Guard that was outside of our emergency department. Welcome to Newton Wellesley Hospital. But with all the presence of the SWAT teams and the National Guard, we thought that this would be concerning for our staff, and the feedback that we got from them was they felt very safe. So the National Guard and the SWAT teams did a wonderful job of working with our staff, but talking to our staff and making them feel at ease, having them in the presence. Recovery is sometimes, I want to call it the lost stepchild of events and exercises. Oftentimes when people exercise, they get up to the point of recovery and they say, well, we've run out of time, so we're just going to move on. But the recovery is a very, very important part of any exercise in any event. And for us, we always have after action reviews, and it's part of the hospital process and it's all part of our regional process. So we do that as soon as we possibly can after an event, so we can discuss if there's any areas of improvement that we want to make for the following year. So one of our big concerns was what if? So what if the bombings did not take place at the finish line, whereas we discussed we have ambulances, trained volunteers, and their minutes from multiple trauma hospitals. So this is what it looks like on the typical marathon day, an aerial view of the tent itself. But what if the bombing took place at the start line? So you have 100,000 runners, spectators, volunteers, and we have one little medical tent that says Newton Wellesley Hospital. It has physical therapists. So this continues to be a concern. So there's increased security along that route as well. So some of the things that we've worked on is mass casualty considerations for any of the large scale events, but specifically for the marathon. They have ambulance strike teams that actually follow the route of the marathon, but they're parallel to the route, so that if something happened along the route, they could then move in quickly onto the route. And that's a sort of a very logistical challenge, but that is something that is worked on through our State Emergency Operations Center. We worked on a grant project for hemorrhage control kits. We provided those to many of the communities along the route. Community hospitals, and I'm going to talk a little bit more about that, need to have not only disaster plans, but mass casualty plans. Additional landing zones for helicopters were identified, as well as reception centers. Some people call them shelters. They don't call these shelters, they call them reception centers. If we had to get people off the route, where could we bring them in? And this is something that's been done. I think it was some years back, there was a severe thunderstorm during one of the marathons in Chicago, and they had to get many people in off of the route. So for a lot of large scale events, there are pre-identified reception centers that can be used to shelter patients, or spectators. Transportation, National Guard support. So one of the things at the start line is that the SURF-P teams, which are teams that could go quickly in, retrieve victims and get them away from the center of wherever the event was, to get them to safety. And the civil support teams, we actually have a civil support team in Wellesley, which is the next town over, so they are stationed along the route as well. So I mentioned a little bit about mass casualty planning, and just as another example of the importance of having mass casualty plans, and not just for hospitals, but for multi-agency coordination. If you look at the concert shooting that happened in Las Vegas in 2017, this was a no-notice event. There were 4 hospitals that were in 4 miles of the event. Many victims were brought to these hospitals by bystanders. They were not all brought in by EMS. They were brought in by citizens. They were brought in by police. They were brought in by any vehicle that could actually transport people. The method by which some of the public decided which hospital to go to, depending on whether they were using Google or Siri to locate the closest hospital. And Sunrise Hospital and Desert Springs Hospital were two speakers that I've actually heard at different conferences and talked about their experiences. Sunrise Hospital is a level 2 hospital. There actually is only one level 1 hospital in the state of Nevada, which I thought was interesting. The level 2 hospital had a mass casualty plan in place. The first 4 vehicles that arrived were actually police vehicles, had 6 gunshot victims in each vehicle. Since they had a plan, they knew this was coming because they'd heard it on a radio. They had stretchers and people with stretchers outside to receive, knowing that people would be self-presenting. They had EMS and a physician outside that was quickly triaging patients. And they had green, yellow, red placements within their emergency departments to put these patients. So just to explain green, yellow, red, green would be somebody who doesn't need immediate care, so they could go into a waiting room. Yellow needs more urgent care, red is critical. So they were able to place patients according to their medical needs. Desert Springs Community Hospital, which was had no MCI plan in place, but they're working towards that now. They did a fantastic job despite they didn't have a plan in place. They had 103 victims came in and only 11 of them came by EMS. So they initially filled up their emergency department beds with triage level greens, which were your least critical, because those were the people that arrived first. Then they had to move them out into the waiting room to wait for additional staff to come in since they didn't have a plan in place. But it's just, I think it just gives an example of why it's important for every hospital, whether it's a trauma hospital or a community-based hospital, to work towards having some sort of a mass casualty plan in place that will help you respond within 15 minutes of an event to have people activated. So just a couple more slides here. The days following the bombing were days and weeks, and I have to say for some, even a year or so. There were a lot of issues with long-term impact for patients. There was psychosocial support needs, long-term significant rehab needs, so physical rehab. We have Spalding Rehab in Boston. They had many of the patients that were there. Because there were so many in that same facility, they really were able to help with a great support system for the patients as well as their families and their long-term needs. The impact on the staff was pretty extreme. There was not one person that I think I spoke to in the course of the year after that was not somehow affected. They were in the race, they were watching the race, they were watching it on TV, they had a family member, but everybody was touched by this. And the same thing happens in any type of a large-scale event. So it's something that is going to impact your staff and it impacts your community. There was an awful lot of outpouring of support, but there was also a lot of cross-hospital support in terms of supplies, in terms of employee assistance programs. But you also have to realize that when something like this happens, you're also going to have to manage things like visits from the dignitaries, whether it's state, local, and on the federal level. And I think they're there to lend their support, but it also adds a layer of planning and confusion that sometimes we don't need at the time of the event. There was a journal project that was written the year after the marathon. And actually the author of this did a fantastic job of interviewing people. Of course, I was interviewed, so I had a little part in this, but it highlighted in the report the preparedness efforts that take place each year, and the long-term recovery efforts for staff and patients. One thing that this was sort of a good article for me in terms of closure from the event, because when you're in a large-scale event, you understand what your part is, what your facility's part is, but you don't necessarily know what's happened all along the route. You don't necessarily know what the long-term recovery plans were. You don't really know sort of the total impact on the community. So this article, and the website is here if anybody's interested, is actually interested in it, available in a PDF format online. It's just a very good piece that explains everything from how we prepare for the marathon, all the way through the long-term recovery of the staff and the patients. So I'm going to end that there, and we'll open it up and see if anybody has any questions. I will open the chat area here.
Oh, Charlotte, that was great. Thank you very much. Yeah, so if folks want to write a chat, or if you have a microphone, you can unmute yourself and go ahead and ask Charlotte. So let me just pause a moment and see if anybody has a question, or an audio question, or even a chat here.
And I'd just like to add that for anybody that's joining us that was involved in this or any other large-scale events, if there's anything you'd like to share, I think that's one of the things that I really enjoy about the Penn State program is the life skills and the life experiences that you all bring to the table, that we all learn from each other. I still continue to learn from the students every year from some of the experiences that they've had.
Along that line also, so we do have sort of 2 social media places where individuals can get in touch or keep in touch. So our PHP option does maintain a private LinkedIn group, and it is for alumni, faculty, and students. And so we keep it as a place where we announce seminars or jobs, or other opportunities that are coming along, and you can interact with people who have gone through the program before you, or who are in the process of going through the program. So if you're on LinkedIn, you can send me a connection to eugene.lengerich, and I'll invite you to the group, and that's a way to keep in touch then as well. The second thing that we do have is a website where we maintain our seminars, and this will go up there then probably tomorrow or the next day by Chulapal. Thank you, sir. And so that you can go back and review presentations that had happened previously, or if you weren't able to actually participate when it took place, you can review them there. So Charlotte, I do have a question for you here. So in the planning, can you talk a little bit about the multi-hospital planning efforts that go on? You showed us an O chart, which I think was for Newton Wesley Hospital. But I'm just wondering, can you talk a little bit about how all of these hospitals coordinate in preparation for the marathon or for other mass casualty events?
Sure. So prior to, there's many planning meetings that actually start around January. So many of them are organized by MEMA, which is our Mass Emergency Management Agency. They tend to hold the larger multi-agency meetings, so we can all, again, talk about experiences from the prior year, any lessons learned, any areas for improvement. The Boston Athletic Association organizes a meeting for all of the hospitals along the route. So we meet usually in probably the middle of March to talk about, again, any experiences, because we all learn from each other, what worked well, what didn't work well, anything that we found that we had gaps, whether it was equipment or training. Boston Athletic has provided an enormous amount of training for hospitals, nurses, and doctors over the years in treatment of hyponatremia, hyperthermia. So, we share, with all the hospitals as well. And then we have another meeting that we hold for our hospital and all of our local for some of the immediate surrounding towns, for fire, police, EMS, public health. And so we do a lot of that. So a lot of it is meetings, you know, from, as I say, from about January until April. We also hold a decontamination drill prior to the actual marathon day, so that we can test out all the equipment and the training that we've worked on with local fire, police, EMS, and the hospital itself. And we do some tabletop exercises. So there's a lot of events. There's probably 10 or 12 different events that will start in January, right after the first of the year, so that hopefully we'll have another successful year in April.
Mm-hmm. Wow. So I guess I'm just amazed at the number of people that must be involved, and I suppose most of you are doing it as part of your responsibility for you, for example, for an emergency coordinator. I mean, this is only one of the potential emergencies that you have to plan for. So I can just imagine that how much time these kind of things take from individual people.
Back in, I think it was 2006, it was an extremely, extremely hot day. And we didn't have a lot of these systems in place. I actually wasn't doing this at the hospital at the time. And there wasn't an awful lot in terms of medical support along the route. Following that, Boston Athletic worked, and Chris Troyanis specifically, who runs the athletic program, along the route. They initially had DMAT tents, and they had Red Cross tents. Now they just have medical tents that are set up. I think there's probably 25 or 28 tents that are set up along the route. So that takes a lot of pressure off of the hospitals, because there's a lot of treatment that can be done within the tents, although many of those patients end up being transported to the hospital directly from the tents to the emergency department. But without those medical tents, the emergency departments would be totally flooded. And the city of Newton that we're in has the longest stretch of route of the marathon of any of the cities and towns. And all of the trauma hospitals are at the end in Boston, and as I say, none along the route. So, you know, we're working hard to try and increase our capabilities in case there were another event that we would need to provide trauma care.
Yeah, a lot of planning, a lot of people.
Mm-hmm.
Yeah, it sounds like you're putting past experiences to good work here.
And you know, it's sometimes it's difficult when you look at your after actions. You don't tend to have the same events over and over again, whereas this is one planned event that we know we're going to have every year. And you'd think that we would just do the same thing every year. We would never have to change anything, but that's not the case. And if you're not finding areas of improvement, then you're not looking hard enough, because you can always learn something from any event that you've done.
Huh. So maybe you don't know, but I have another question, a very specific question here. So I think you mentioned that you all didn't have enough amputation kits.
Correct.
So what's in an amputation kit, and what did you do about that?
So I don't know the exact contents. There's orthopedic equipment and saws and drills and all kinds of great things. But there were not enough kits readily available directly in the trauma hospitals in Boston. I think most hospitals tend to each have one kit. You know, you can use the kit and then you can sterilize it. So amputation is not something that is fortunately done on a grand basis. So we actually were transporting kits from outside of the city into Boston. So we had EMS that were picking up kits and transporting them into the city hospitals. Since then, through some grant funds through our Northeast Regional Advisory Council for Homeland Security, we've actually purchased 22 kits that are located in hospitals outside the city. So they could be transported either into the city or in any of the regional hospitals if need be.
Okay. Interesting. Yeah.
And I think
Well,
one big thing that has come out of this, in terms of the use of tourniquets, the Stop the Bleed program has really taken way across the country. So, you know, having access to tourniquets in any community is really becoming the norm. And the training through the Stop the Bleed program, I think, is very instrumental in community planning.
yeah, it's taken over big time here in Hershey. Yeah, good, good. Well, we're almost at 9 o'clock. Anybody with a final question or comment? Well, I don't hear or see anything else. Charlotte, thank you very much for taking time out of your evening. We really appreciate this. And like I said before to everyone, we will post this on our seminar website. Julep will take care of that in the next couple of days so that you can review it again or encourage your classmates or other people to be able to take a look at it. Again, Charlotte, thank you very much. This has been great, very good, well prepared, and very interesting.
Well, thank you for having me. I enjoyed it, and appreciate you having me tonight.
Great. Okay, everybody, have a good evening, and thank you for joining in. Thanks, Julep, for helping us out here.
Good night, everyone.